Hi everyone, Dr.Jyotsna here. I will be talking about tachyarrhythmia, the simple tips which I always helps me. Whenever the patient is in tachyarrhythmia, you have to see for hemodynamic instability. If the patient is hemodynamic unstable or there is sign and symptom of hypoperfusion, you have to give shock. The shock will be synchronized other than in VF. Whether where you have to give a defibrillated dose, and if it is stable arrhythmia, then you have to see whether it is regular or irregular. If it is regular, now you have to see whether P wave is present or not. If the P wave is present, means it is sinus rhythm. If the P wave is absent, then it is and regular, it is PSVT. So you have to give adenosine 6 mg, then 12 mg you can, with followed by flush, NS flush. If it is a regular with regular narrow complex with sawtooth pattern, not P wave, sawtooth wave pattern, then it is atrial flutter. Then you will have to manage as atrial fibrillation. And if it is narrow but irregular, either it will be atrial fibrillation or multiple atrial tachycardia. If there is no P wave, then it is atrial fibrillation. If there is a P wave, then you have to see if there are different P wave morphology of greater than 3 or 3, then it is multiple atrial tachycardia. Atrial fibrillation, you have to see whether it is less than 48 hour onset AF or it is chronic AF more than 48 hour. Why we have to see for any thromboembolic risk factor. If there is a more than 48 hour, there is a high chances of thromboembolic risk factor, and if the patient is not anticoagulated, he has not received, he is not on anticoagulant, you can't cardiovert or you can't give any antiarrhythmic agents, because there is a high chance of thromboembolic stroke. So in that case, if this is more than 48 hours, you will have to do give anticoagulant, and then only you can cardiovert. Till then you can control the rate. You can control the rate according the base of the patient's ejection heart, if left ventricular ejection fraction. If it is normal, you have many drugs to control the rates. And if it is irregular, if it is abnormal, that is a low ejection fraction, then Delgem, dioxin or flecainamide are the options. So you can start with do that. If it is less than 48 hour, you can also use Codron. So Codron 150 mg over 10 minutes, then you can start as an infusion 1 mg per kg per hour for 6 hours, then for 18 hours 0.5 mg per kg per hour. So in this way you can start in that. So if you have you want to cardiovert the patient and this chronic AF, and the patient is not anticoagulated, you have to do TE and see if there is any clot in the LA or anywhere in the clot or not. If it is no clot, you can just do anticoagulation for 24 hours, and then you can cardiovert, and then you can continue anticoagulant for another 3 weeks. So this is how we go for it. And now come to the broad complex tachycardia. And this also you will have to see whether it is regular or irregular. If it is regular, you have to see whether it is monomorphic or polymorphic. Polymorphic means torsadepanta, the magnesium is the drug of choice. If it is monomorphic, it is VT. You have to antiarrhythmic agents you can infusion you can take, or you can give first you can start with Codron, you can give 150 mg in the same way, or procainamide or sotalol are the options. And you have to take the expert opinion. In the same way, if it is VF, you have to give cardiovert the patient. And in all cases you have to find out the cause. You have to see for the any cardiac issue like MI, or you have to see dyslipidemia or COPD or other causes which may cause this. I think multiple atrial tachycardia treatment I have not said. It is magnesium. M for magnesium, M for multiple atrial tachycardia. Thank you.